it means you work with what you have at that time. You try and get to better alignment, better motion. Please don't just leave them. But also you have to know what you're doing. Start where you start. Progressive, sequential stretching. Okay, so anyhow, he was able to get rid of his trach down the road. These are his feet prior. They also call vertical talus Persian slipper foot because it tends to look like a Persian slipper. So we started the casting. With clubfoot, the feet go down and in and into Aquinas. All right. With vertical talus, they come up and out and into valgus and dorsiflexion, and the talus is dislocated distally. Okay. So through stretching and casting.
Oh, ready?
So he was stuck in Persian slipper position.
Our motion.
And this is the motion that we were able to get through stretching and casting. Stretching and casting. He hadn't even had his sonata yet. And then, the other side.
Okay, here's his motion of his foot. Up and down.
That's beautiful.
And
We also know that as he grows, because he has arthrogryposis and he has artergium, we know he's going to need more treatment. But we also are not going to wait. He now is 8 and he's come back repeatedly for different procedures. We know down the road he's going to need some spinal correction surgery as well. But he's independently walking, he's independently feeding himself. And I really didn't show you pictures of his whole body. They're from the Hasidic community in Jerusalem, and they do run a flash show. But I'm saying, don't just say, I don't know what to do, right? So and if your center doesn't do it, help them find a center that does. Coordinate with a center that does. Because guess what? We can't see all the kids in the world like this, nor do we want to. We want to train folks. And what we do is they may come to us for a period of time, but we're trying to help the hometown therapists take over the care when they go back home. So we're giving them videos, we're giving them literature, we're giving them handouts, we're giving them these things. And then we support them with phone calls, with telemeds and things like that. We also have the course that we run, and we have preceptorships that we run. What I tell families to look for most when they're going home is a therapist with an open mind. A therapist that's willing to take guidance from us, because more often than not, the therapist at home has never seen their diagnosis before. There's no shame in that. There's no shame in that. But there is shame in saying, there's nothing we can do, I'm not willing to do it, the book says X, Y, Z. The book says don't stretch them. No. Or I know exactly what I'm doing. No, please take guidance, please be open-minded. That's all I'm saying, please be open-minded. Okay. That was vertical talus. Let's move on to clubfoot, or congenital talipes, equinovarus. It is detected in the second trimester of pregnancy with ultrasonography. It's a developmental deformation, 3-dimensional deformity of the foot. It occurs, this is the most common, 1 in 1,000. It occurs twice as often in males as compared to females, and approximately 50% of presentations are bilateral. And if it's unilateral, the clubfoot side is going to be slightly smaller than the non-affected side. That means the shoe size may be a little bit smaller, but also the girth of the leg is a little bit smaller. So Ponseti manipulation stabilize the talus while manipulating the foot into abduction underneath the talus. So you use the talus as a fulcrum while your hand stabilizes the talus. So you have 2 points of, 2 points of connection on that foot. One, your thumb is stabilizing the talus, and then you're bringing the foot around into abduction first. And then after that's corrected, you can go up into dorsiflexion, but 95 to 99% of these kids are going to also need a tenotomy. Each time you get some correction in between casts, then you put a new cast on and you mold it perfectly to stabilize that, correction that you achieved, and let those muscles elongate over the next few days. Full correction is achieved when the foot is abducted roughly 60 degrees in relation to the tibia, and dorsiflexion of 10 to 15 degrees. 90 to 95% of these children require Achilles tenotomies. I would say of kids with arthrogryposis with clubfoot, 99% require tenotomies. And then you want to do, and we're talking right now about a child with just idiopathic clubfoot. So with children with idiopathic clubfoot, they're going to be bracing for 4 to 5 years. So this is a child with clubfoot. It has cavus, equinus, adductus, and varus. You see that? Everybody? Yes? Cavus, there's a line across the foot where they're curved. Equinus is another way of saying plantar flexion contracture. In orthopedic surgery, we refer to it as an equinus contracture. Varus, everybody knows what varus is. This is calcaneal varus. And adductus. The whole foot is adducted. Okay. Treatment: Ponseti manipulation and serial casting. French functional method of is a method of manipulation with taping, and then there's surgery. So the gold standard for treatment back in the day, again, this is a situation of if you don't ever try something new, you'll be exactly where you are. So posterior medial release is like a disarticulation of the foot and putting it back together in the proper position. That was the gold standard before Dr. Ponseti printed his book in 1992. He came up with his techniques back in the 50s and 60s, and he was shunned. He was shunned, saying that you could correct these children with serial casting and tenotomy. If he'd stopped there, he'd still be doing this. And what his studies, so what he did was go to the research. He did long-term research on kids who had the posterior medial release and on the children who became adults that had had his gentle method of manipulation and serial casting. He also did histological studies. So on fetuses that did not make it, that were born with clubfoot that died, and he found that the fibers of their gastroc and their posterior tib and other muscles within the lower leg were crimped. They did not have normal muscle fiber, and so they lent itself very well to elongation, and it would stretch out. So he published, and then he published a book, which was published in 1992, and over time, it still wasn't adopted right away, but over time, that became the gold standard of treatment. So now, the Ponseti method is the gold standard of treatment. Again, evidence-based is excellent, because you have to get there. But if you're going to only accept what is exactly done, and you're not going to say, this isn't working, when it's not working, and think of new things, the first thing we need to learn is do no harm, right? So if we're gonna do something that's different, is it going to harm? That's what I think about when I have a new case that is an outlier, even in our outliers. Where do I start? What do I do? One is no harm, right? How can I affect this child? How can I help without creating harm? When I was thinking about the spinal electrical stimulation, right? I'd already been using peripheral stimulation, meaning stimulation like, say, to the quadriceps. I've been using that since I started practicing on babies. I had. Some people don't want to touch babies with electrical stimulation. Why? Why? Their physiology is the same, right? Don't be afraid to do that. I have therapists from all sorts of places saying we don't use electrical stimulation on children. Why? Why? It works on children just like it works on adults. So when I first saw the spinal electrical stimulation, is this going to do harm? What harm could it do? So I go and read. And I tried it on myself first, and my colleagues and I tried it on each other. And then we brought Gertie to our facility to teach us about it. We looked into what exists. We know in this population, it's very helpful. We've got documentation that in the population with kids with spina bifida, it works very well. Okay, so why would it be different in this population? And I will say that both Mary Pingelli and her practice in West Palm, I think she's still adjunct here. You guys have Mary present yet?
No.
She's amazing. She's amazing. Yes, no? Yeah, she's amazing. I highly respect her. But so in her practice, she started using it on kids with cerebral palsy as well. And we are too now. But that's, again, just because it hasn't ever been done doesn't mean that you can't do it. Look at the literature existing in the position or in the situations that it has been done, and you do it in this other population. Okay. All right, and then also it talks right here about the French functional method. It's a method of taping. So here's another thing that I've kind of pioneered is I do both. So a lot of kids with clubfoot and arthrogryposis, their toes, you'll cast them and their toes will start crossing because everything's so tight. So I personally had a foot surgery and I had used kinesio tape to help realign my toes after my foot surgery. And I thought, why can't I do it here? They're itty bitty toes, but what can I do to keep those toes from crossing? Because the doctors would say, oh, they're just toes, they don't really matter. Well, very disturbing to parents when their toes start crossing. But it was common, So I started taping them underneath the cast. And now I cannot tell you the last baby that we've had toes cross on. It's a simple piece of 2 or 3 pieces of tape. It's an easy thing to do. So I kind of combined that, and we also have, we may even put a piece of tape underneath to help maintain the correction, because some of these babies are really, really, really challenging. If they have idiopathic club feet, so easy. But the other ones, the other deformities are much harder. Okay. This was patient 0 for our center. And I'm going to tell you, I think I told you at the beginning, Dr. Paley said, you're going to open a clubfoot clinic. And I was so overwhelmed with the lengthening practice. I thought, I'm not doing that for 6 months to a year. No way, no how. Well, it was a weekend, I think it was Labor Day weekend, where he called, and this is how we roll. He called, he says, hey, I have a friend that's coming into town. She brought her clubfoot model. She's going to teach her staff how to do this. So Dr. Monica Noguera, who is a world-renowned clubfoot specialist from Brazil who had done a fellowship in Baltimore with Dr. Herzenberg, who was one of Dr. Ponsetti's trained colleagues, so he's one of the world leaders, and she had done it under Dr. Herzenberg and Dr. Ponsetti. I think she'd done it in Iowa also. And she went back to Brazil. Now, originally, Ponsetti said for kids under 1, okay? And then he started expanding that to older kids. Well, it had not been done on teenagers. Trust me, they would do the posterior medial release. So Dr. Nogueira went back to Brazil and she started treating neglected clubfoot. So older and older children with club feet using the Ponsetti method. It's harder at that age, I'll tell you, but it's possible. Because with the surgeries of the posterior medial release, first of all, that's way more expensive. That's way more disruptive. And these kids tend to scar more than folks without clubfoot. So they were developing a lot of stiffness. So she wanted to see if she could make it better. And she corrected feet that had been neglected for years and years with casting. And she did amazing things. So I had the absolute honor of being trained in the Ponsetti method by Dr. Monica Nogueira. And she came to my center with her little clubfoot models at the end of a 12-hour day. And they said, here, you're gonna have this training tonight. Okay, fine. So we stayed like another 5 hours and learned how. I'd never applied a cast. She had her models, we worked on the manipulations, we worked on the casting. It was a lot. And then, by the grace of God, this baby was born in the hospital that week, and she was there. And I got to go to the NICU, he was in there for jaundice, and she gave the family education. And then she flew away, and I had to treat him. I was terrified. Because if you put a cast on a child, or anybody, bad things can happen if you don't know what you're doing. And thankfully I had a good team of doctors. I had Dr. Paley at the time in our center, and we had some orthotechs that had worked with him. And then I had my PTA who had worked with casting before. But we did fine. We did great. This child did amazing. So that was our first one. He had idiopathic clubfoot. That's awesome, because the next one did not have idiopathic clubfoot. The next one actually had arthrogryposis with clubfoot. And then we had pterygium with clubfoot. And then we had it just got worse and worse. So we were baptized by fire. But things went well. I would say I wish I'd known then what I know now. I think we had even better outcomes on a few kids, a few less casts, but they did well. So this child was diagnosed in utero at 20 weeks with an ultrasound. Not all of them are. We still get kids that are born and the parents have no idea. But more often than not, they do. So we began at 3 weeks old with the Ponsetti method. That's an x-ray of his feet. Ponsetti did not do x-rays because he wanted his method to be able to be used throughout the world where they don't have all these resources. We don't use x-rays on newborns anymore, but we did back then. And so this is after casting, but before tenotomy. So let's take a peek. You can see the angle he's not neutral. And he's starting to get a little bit of a rocker bottom, which is not what you want. So we know he needs the tenotomy. So the tenotomy, they do it in the office on newborns, on little babies up to about 6 months old. So depending on the surgeon, some of them will inject like a little lidocaine right around the Achilles tendon, and then go in and do a quick tenotomy. We're in the office with that. I'm holding, assisting often with that, and then we manipulate him into correction, him or her, and then we apply the cast after that. If it's more than 6 months old, they typically go to the OR and have a light anesthesia or a quick anesthesia. It's literally a procedure that takes less than a minute on each foot. The prep time takes much longer and the casting takes much longer than the tenotomy. Anyhow, so this is after the tenotomy, and now you can see there's truly dorsiflexion. Okay, where before, I'm going to go back for a second, there's none. Okay, and it's starting to get a little bit of a rocker, which is not good. So tenotomies, and then the kiddo did great. Sorry, he's now a soccer player. He is, that was 2009, he's, gosh, 15, 14, 15, anyhow, time flies, almost 15. So, this is a child with arthrogryposis. She had the flexion type, and she had bilateral clubfoot. This is what she looked like before surgery. You can see the flexion contracture of the knees. You can stretch those hamstrings all day long and you are not going to get straighter at that point. So he did, oops, I'm sorry, he did a femoral shortening. He did, so this right here, shortened the femur and then you put plates and screws in until he got it. You can see the plates and screws there, but not as well, until he got the knee fully straight. This is her prior to the surgery. She's walking. So she's 3 there. Do you think at 13 she'd be able to walk independently? She wasn't even walking independently there. All right, so she's little there. She's raised, and she's walking. So they might say, "Oh, that's good. That's great. Leave it like that." But she wouldn't be a walker long term like that. So this is her about 3 to 6 months after the surgery. She's just silly. And she really doesn't even need the stroller at that point. She's just, this is the video that Mom sent me. Walking around, doing her thing, being funny. Okay. So this is her a year later, 1 year after the surgery. And Mom took the video, and she's just walking through Old Navy, doing her thing, being sassy. Now, so she's become really, really active on the arthrogryposis websites. They have, just like every diagnosis, they have like networks, right? And she's really an influencer on there, and they follow her. A lot of families have come to us because of Sophia and some of our other patients who have been very active on social media. I honestly have mixed emotions about kids being on social media like that. I think that, anyhow, she likes it. She's now a teenager and she's going to regular junior high with no assistive devices. She's making a video for her followers talking about how to get up and down curves. So my point is, she's living a normal life. She doesn't wear braces. She doesn't need assistive devices. She plays the piano, and by the way, because this is a PT lecture, I didn't show a ton of hands, but the hands are very effective in a lot of these conditions, and or in arthrogryposis, and she's living normally. She does her own hair. She takes her own shower, she dresses herself, she eats independently, she cuts her own food. For somebody with arthrogryposis that hasn't been treated with early intervention, that does not happen. And this is her climbing up the stairs. And she goes up and down stairs independently. independently. She's amazing. And it's not just her. It's not just her. That's the one that's in these lectures. If you want to see other cases, you can go to our website. Some of my videos are on there. We lost power in that, didn't we?
Yeah, looks like it.
Thankfully, there's only like 1 or 2 more slides, but, so on our website for the paleyinstitute.org, you can go to the rehab section. It's kind of hard to find. You have to go up in the little, I think they call it a hamburger, up in the corner and go to rehab. And you can see some presentations that I gave during 2020 where nobody was giving it in person, so I like embedded my lecture into each slide. And you can see some amazing outcomes of kids that are extremely severe. Some that were able to greatly reduce the surgeries they had to like only just 1 surgery on 1 leg. And some that didn't need. We had this morning actually some little girls that were born during 2020, identical twins, and we have lots of identical twins that come with arthrogryposis. Lots, not just 1, not just 2, lots. And this set was born, family lived in Washington, D.C., they moved down here, and all the child has had is early intervention. She didn't need not 1 surgery, not 1 surgery. And I tell you, when she and her twin walk in the door, it's hard even for me to determine which child had arthrogryposis. After I look a little bit, I can see, and she is shorter than her twin. But not all outcomes are going to be that great. But I can guarantee you with some intervention, it's better than not. I just beg you not to just go, oh, don't stretch, don't move them. They're going to be what they're going to be. Please, let's help them. Okay? So remember that paradigm shift slide that I had up there? And remember how I said a lot of people think that it should be treated one way? And I'm going to throw some information at you today that may shake you up a little bit. So I hope that you're closer to this outcome over here, accepting that there are other ways to treat things than how you may be reading in your book. And I hope if you get some of these kids or adults as they grow up and you don't know quite what to do and the doctors are recommending something that doesn't have to be, I hope that you remember that there are other options and tell them about it. Okay, questions? Nothing? Really? Guys, come on, nobody has a question?
I actually did have a question.
Thank you.
Are all of these covered through insurance, or some of them kind of like full?
That's a great question. So, most of them in the US are covered through insurance. But those that come to us internationally are a mixed bag. So we have a lot of embassies that send us patients from different countries. The Middle Eastern countries that are oil-rich countries, their embassies pay, and quite well, and their families get huge stipends to be here, so they get all their expenses paid. Pretty cool for them. I wish we had that healthcare system, but we do not. Most insurance companies pay for the surgeries here, but they may have limited PT or OT benefits, or they may have like 30 visits a year, okay? And that's really hard to get through a lengthening when you're supposed to be getting PT 5 times a week. And I will tell you, our cost for out-of-pocket PT is higher than other centers. Remember what I said, that therapists come, and I don't care if you've got 20 years of experience, you're going to be trained with us for 2 to 4 weeks before you touch a patient or have your own caseload. There's a lot of expense in our center, training people, supporting, so we're more expensive. But we work with folks, and we work within the parameters, and we write a lot of letters of medical necessity. We do peer-to-peers. So we don't give up. And families find a way to make it happen. They really amaze me. Families amaze me. They do GoFundMes, they do fundraisers, they sell t-shirts, they're amazing. They're amazing. And we do some pro bono cases. Medicaid will pay for the surgeries, but they never pay for the rehab at our center because it's more expensive. And if they go back home, they don't particularly know what to do. So we will do some Medicaid patients pro bono, or other patients that don't have funding. We will also help to train the local therapists. So we work with telemed as needed, we work by sending videos as needed. We really try and meet them where they're at. So we also do, which I haven't talked about yet, we do stature lengthening. So what is that? Anybody want to take a guess? What?
Lengthening the torso?
Mm-hmm.
Just kids
Good
want to
guess,
be
though.
taller.
So stature lengthening is a form of cosmetic lengthening. We do actually do spinal correction for scoliosis, and that actually lengthens the torso. It straightens the torso. But we do stature lengthening of the extremities for cosmetic reasons. I will tell you, quite frankly, I had a moral dilemma about that initially. I was like, what are we doing? But it wasn't like I was being asked. They were coming to me after they had the rods inserted, right? I had a moral dilemma until I saw many patients come to us from other centers, totally normal patients that wanted to be taller, that had this done at other places and came to us with horrific and crippling deformities. And then we had to fix it. Sometimes you could fix it with some soft tissue releases and stretches, and many times they needed fixators to, anyhow. That's a whole other can of worms. But after seeing that repeatedly, I no longer had a moral dilemma, because they're going to get it done. They're going to get it done somewhere. They can go to India, they can go to different places in the US, but they don't know how to manage it. Because unfortunately, it's easy to put the rod in. That's easy. And it's easy to teach them how to use the external remote control. What's not easy is the management of the soft tissue, what we do. I'm not saying the other one is easy. Like if you have a bad surgery, it's not going to go well, right? But if you have a great surgery, but you don't have the PT to follow it, and the bracing and all of that management, and if the doctor doesn't know how to follow it post-operatively, you can destroy a limb. And so I no longer have a moral dilemma with that. I wish our society was such that we could accept people however they are, and that people that were shorter or larger or taller didn't feel like they were being victimized. I wish we were employed, but the fact is that people feel that way. And you know, if a woman has smaller breasts and a guy says, wow, I'd date you if you had bigger boobs, that's atrocious. But women say that to men all the time. You gotta talk really loud, I can't hear you. So yes, absolutely. Well, a couple of reasons. Some of them look at it as purely cosmetic. A lot of folks in the, with dwarfism, whatever the form, look at it as we are fine exactly the way we are. Perfect, that's great. If you feel that way, that's great. Okay? Have you guys ever heard of cochlear implants in the deaf community and how some of the deaf community does not accept that? I liken it to that type of attitude. And I'm not judging. I'm just saying there's treatments available. Okay? There's treatments available. When I was at the first ALPE convention in Europe, I sat next to, you remember there's been various shows of folks with dwarfism? Well, I sat next to one of the folks that had a show. And I thought, oh, I'm gonna get eaten alive, because I knew how they felt, right? And I sat next to her as they were doing the presentation on BioMarin, the medication that helps block the receptor so that they grow more normally. Okay, and I sat there and she says, I really thought I was going to be totally against this. I'm thinking, why would you be against something that would prevent the deformity in your child? I mean, I'm not judging. I guess maybe I am. I'm trying to look at myself honestly here. I'm not trying to judge. I'm just shocked being a parent of 3 kids. Like, if one of my children had something that was going to be life-altering, but there was a medication that could change it and not be harmful, I would want it. And I really think that that's the whole thing. If your family decides that that's the course they want to go, and it's not harmful, I don't think that a doctor should not give you that option, right? So, and if you're an adult with dwarfism and you don't want to, fine. That medication only works on children, by the way, but lengthening works on all ages. If you don't want to do it, that's fine. If you have children with dwarfism and you don't want to do it, that's fine too. That's fine. But don't ridicule those that have had it. And I will tell you, our patients that have dwarfism that have chosen to lengthen are not accepted at LPA. They are not accepted there. And that to me is very disturbing. We're trying to bridge that gap and trying to get them, to be more accepted. That we have patients who are now on staff that have gone through lengthening, and they're trying to bridge with those programs because they've been to Europe, they've been to Alpe, they've been to those other programs, and they see that, hey, we don't have to go against each other. Let's go for each other, right? Let's say that different options are okay. Other questions? No? Okay. Thank you very much. If any of you guys down the road are looking for clinical internships in this, we do accept students. We accept top students, so get your grades in there and be a standout in a good way. And if you're interested in that, contact me early, because I have certain things that I require, such as I really like the students that come to us to have done their inpatient rotation at St. Mary's Hospital, where our patients do their inpatient time, and so they have some inpatient experience with it. And so I also like folks that are interested in pediatrics and orthopedics, obviously. But so if you're interested in those things, and this was extremely interesting to you, we do accept interns. I will also say that of my staff, a lot of my staff started as rehab aides with us and then went on to PT school, and then we've had a few that came back and did their rotations with us. And I have a lot of staff that has either done rehab aid or clinical rotation and then become hired by our team. So, all right. Thank you.